Okay, in chapter 18, we're going to cover depressants. We're going to actually want you to know the terms, medications, any kind of side effects, because of the fact what it can actually do to the different organ systems. So you want to drugs that are central nervous system depressants, of course, can cause varied degrees of depression within the central nervous system. The degree of depression depends primarily on the drug and the amount of the drug taken. The board classification for central nervous system depressants includes sedative, hypnotics, general anesthesias, analgesics, opioid and non-opioid analgesics, the anticonvulsive and antipsychotics, and antidepressants. Now, with sleep disorders such as insomnia, it occurs in 10 to 30% of Americans. But insomnia occurs more frequently in women and increases within the age. Now, normal sleep is composed of two definite phases, which is the REM, rapid eye movement sleep, and non-rapid eye movement sleep. Both the REM and the non-REM, or non-rapid eye movement, occur cyclically. It just cycles during your sleep at about 90-minute intervals. Now, before using the sedative hypnotics or over-the-counter sleeping aids, various non-pharmacological methods should be used to promote sleep. And you can look in your chapter for different suggestions. You're going to look at meditation, different things to avoid. You don't want to have the TV go on and actually stimulate the brain before going to sleep. If you're having issues with sleep disorders. So remember, the mildest form of central nervous system depression is sedation, which diminishes physical and mental responses but does not affect consciousness. Sedatives are used mostly during the daytime. Now, sedative hypnotics increases with drug dosage can produce a hypnotic effect, not hypnosis, but a form of natural sleep. With very high doses of sedative hypnotic drugs, anesthesia may be achieved. And you see a lot of the people start becoming dependent on it. Look at Michael Jackson. And there's so many things that are they're looking at now and trying to avoid prescribing because of those accidents. So you have with sedatives, which are actually sedative hypnotics, you have initially used to treat for tension and anxiety. Now they're starting to pull back on that because of the fact so many people were getting addicted to it. Sedatives were the first prescribed back, say, in the 50s. They had barbiturates. They were used, prescribed, especially for women in premenopausal, postmenopausal, and used for anti-anxiety until the early 1960s when the benzodiazepines were introduced. Because you could see even they would, if children had allergies, different things like that, they didn't have ADHD medications back then. they would actually prescribe the benzodiazepines, which is basically Valium. So because of the many side effects of the barbiturates, then the potential for physical and mental dependency, they are now less frequently prescribed. Now, the primary ingredient in over-the-counter sleep aids is antihistamine. You'll see in all of the labels like nighttime Motrin, or you'll see Tylenol PM, all of that. Well, you'll see the drill is it's just basically Tylenol and Benadryl. It's the let's see. Now, there are short-acting hypnotics and intermediate-acting hypnotics, and then the short-acting hypnotics are useful for achieving sleep. It just gets you in the REM state, basically lets you slow your mind down. Intermediate-acting hypnotics are useful for sustaining sleep. Now, the ideal hypnotic promotes natural sleep without disrupting normal patterns of sleep and produces no hangover or undesirable effects. And you see some people going in with essential oils now. You have the different natural herbs. But with that being said, especially with the herbs, when you go in to see a physician, you always want to address that you're taking that medication, because that will you might have a side effect with what they're prescribing. Because the basically Valium, benzodiazepines can cause a tolerance, which actually means an abrupt cessation can result in withdrawal symptoms. Now, that is one thing. With that being said, you never want to abruptly stop alprazolam or benzodiazepines, anything like that, because it actually can cause major side effects. Now, the non-benzodiazepines, as a hypnotics, you have the zolpidem. It's a neurotransmitter inhibitor, and then during action is 6 to 8 hours. It's actually a short-term used medication for less than 10 days to help with insomnia. Now, patients with severe respiratory disorders should avoid hypnotics, which should cause an increase in respiratory depression. And with the category of the sedative hypnotics, including barbiturates, benzodiazepines, and the non-benzodiazepine, among others. Barbiturates are classified as long-acting, intermediate-acting, short-acting, and the ultra-short-acting. A lot of people now are going to the melatonin agents because the melatonin agonist is a natural remedy that our brain actually produces a melatonin. It's the first FDA-approved hypnotic not classified as a controlled substance. Now, selectively targets the melatonin receptors regulates the circadian rhythm to treat insomnia. It's not been shown to decrease the REM sleep. Adverse effects may cause drowsiness, dizziness, fatigue, headache, nausea, or suicidal ideation, which you'll see that with every single medication that could actually cause a lawsuit. So they have to list it. So the barbiturates that are classified, the long acting, intermediate acting, short acting, and ultra short acting, is used a lot to control seizures and epilepsy. You see that diazepam used, or diazepam, you inject that rectally to a patient that is having a seizure more than 2 minutes. And that's just a standard protocol because of the fact you don't want anything, they can't take a pill orally, you have to use it and monitor the airway. And of course, when you do something like that, if you are treating a patient and you're in a home health environment or out of the hospital setting, of course, you would have to call 911. The long-acting group is used to control seizures in epilepsy. The intermediate acting barbiturates are useful in the sleep sustainers and maintaining long periods of sleep. The short-acting barbiturates are usually primary for sedation preoperatively. The ultra-short acting barbiturates are used in general anesthesia. Now, barbiturates should be restricted to short-term use in 2 weeks or less because of their numerous side effects, including the tolerance for the drug. Now, many interactions are associated with barbiturates. Now, the benzodiazepines increase the action of inhibitory neurotransmitter, the gamma butyric, which is GABA. I always call it GABA, the receptor. The neuron excitably is reduced. It actually will start suppressing that natural GABA. And the benzodiazepines, except for temazepam, can suppress stage 4 of the non-REM sleep, which may result in vivid dreams or nightmares and can delay REM sleep. Now, one adverse effect closely associated with the benzodiazepines is the retrograde amnesia, which they give that when conscious sedation through, like if you're doing a colonoscopy, they usually did that so you will forget and that you actually had the procedure. You would feel it, but you won't remember it. Impaired ability to recall events that occur after dosing. Zolpidem is a non-benzodiazepine used for short-term treatment of insomnia. Melatonin is the newest category in the sedative hypnotics called melatonin agonist. This drug acts by selectively targeting melatonin receptors to regulate the circadian rhythm in the treatment of insomnia, like I talked about earlier. It's just identifying the cause of the insomnia is the best thing to do. And especially in the older adults, should first diagnose the consideration non-pharmacological methods should be used before sleep medication is prescribed. Now we have barbiturates increase the central nervous depression and confusion in older adults and should not be taken for sleep. The short to intermediate acting benzodiazepines are considered safer than barbiturates. Now you'll see a lot of older um, patients that were actually in the 50s, 60s that were put on Valium or put on Xanax, and they have been on them forever, and they've built up tolerance. And you can go in to assess them and get a false positive on dementia because of the fact they're on a higher dose, and so therefore they're not going to be as alert as they would be, and even the speech may be altered. So you have to really know the medications they're on. Anesthetics are classified general and local. General anesthetics depress the central nervous system and alleviate pain and cause a loss of consciousness. Now, balanced anesthesia is a combination of drugs frequently used in general anesthesia, because you'll see the balanced anesthesia may include hypnotic given the night before, and then they'll pre-medicate, like they call it a cocktail, with the opioid anesthesia or a benzodiazepine, and then they'll add an anticholinergic. And now we'll have balanced anesthesia minimizes the cardiovascular problem, which it decreases the amount of general anesthesia needed, because more general anesthesia and over a repetitive number of time have shown increased cases of dementia, because it causes problems long term. It reduces the possible post-anesthesia nausea and vomiting, also minimizes the disruption and disturbance of organ function, which we have to really look for in elderly patients that get an obstruction or ileus. And then we have it decreases the pain. Now, general anesthesia proceeds through 4 stages. Now, you'll have to look at that and refer to the table 18.4, because a surgical procedure is usually performed during the 3rd stage. It depends on the procedure you're having. So, the patient's response to anesthesia may differ according to variables. I mean, it's related to health issues, genetics. They say redheads totally have a different response to anesthesia than another ethnic group. We have these variables include age, current health disorder, pregnancy, history of smoking, frequent use of alcohol and drugs during the 3rd stage of anesthesia. You'll get the inhalation, where and used to deliver the general anesthesia. Those anesthesias typically provides the smooth induction. You will see that in the past, say for instance during labor, you would have more patients, most all patients had the general anesthesia. Rarely do you see that now, in a labor setting or, delivery status because they use a spinal epidural because of the fact they've seen residual effects on the fetus, newborn. So we have to see that actually more and more they're using general anesthesia less, unless they just have to. Now that you will see it on more children because of the fact the age and how they have to stay still, and but they're finding it's not a great thing. They're going away. Inhalation typically provides smooth induction. Again, continuing the administration of halothane, isoflurane, and enfurane. Recovering of consciousness usually occurs within approximately 1 hour. And you'll see that they will actually wake them up faster than that, even an hour, because they're usually out of the recovery room unless there's complications within 45 minutes. Recovery of the desflurane and the sevoflurane is within minutes. Inhalation anesthetics are usually combined with a non-barbiturate, a strong analgesic, and a muscle relaxant for surgical procedures. Now, intravenous anesthesia may be used for general anesthesia or for the induction stage of anesthesia. For outpatient surgery, the short duration intravenous anesthesia might be preferred over the short term. The intravenous anesthetic might be preferred over the anesthesia. IV anesthetics have rapid onsets and short durations, so that's why they were preferred. Just use a topical anesthetic agent is limited to mucosal membranes, such as dental work, and then you have the broken or unbroken skin surfaces and burns. Local anesthetics block actually block pain at the site. You'll see a lot of times they'll put that before starting an IV in some hospitals. You have it actually prevents the conduction of nerve impulses. Now, most local anesthetics are divided into two groups. They're the esters and the amides, according to the basic structures. Spinal anesthesia requires that the local anesthetic be injected into the subarachnoid space at the first lumbar space in adults and the third lumbar space in children. Now you got to remember, when you're doing a spinal anesthesia, you always want to encourage the patient to lay flat 6 to 8 hours. You don't see that done as much anymore, and they don't promote it because of the fact they have seen that they don't have the residual headache like they have in the past. But you will see that if they move around too much, you actually can have what they call a spinal leak, which they'll have to go in and give them what they call a blood patch to block that actual leakage, because you don't want to lose your spinal fluid. but for the sake of knowledge, you have to lay flat for 6 to 8 hours with a spinal post anesthesia. Now you have spinal nerve blocks, and you're seeing more often in orthopedic surgery for shoulders, for hips, knees, different things that will be last longer than what you would see a spinal last, because of the fact they're trying to use less pain medication. If the local anesthesia is given or spreads too high in the spinal column, this is why you want to know your dermatomes and where you check them to when they're waking up, because you actually can cause, if it goes too high, the respiratory muscles could be affected, and respiratory distress would be imminent, and then you would actually have respiratory failure as a result. So when you'll start seeing decreased blood pressure, so you call the anesthesia or CRNA right away, and you get them, and they will come in and administer atropine, and then you will have to wake them up and actually get them to sit up to lower that to the bottom, especially if it was what I'm talking about, my field is you would actually sit them up, and it would come down to where they would start feeling it. You would just usually soft, something soft, or you can actually use a pen or to see what place they start to feel the sensation again, and then you can have them lie back, because you want them to relieve from pain or the contractions or any other procedure. Now we have a slide, as you just look over the different on slide 25 and slide 26, you're looking at the nursing process, and look over those to see, and slide 27 as well. The post-dural puncture, as we were talking about, the headache could result from the spinal anesthesia, possibly decreased in the cerebral spinal fluid pressure. And sometimes you will see that. The various sites of the spinal column can be used for a nerve block with a local anesthesia. Blood pressure should be monitored, and you'll see that, especially in big hospitals, while you're doing or giving or helping assist with the spinal epidural or spinal period, you will monitor those blood pressures every 2 minutes until you have a level, and then you will be given a bolus of LR, or actually some hospitals use, depending on the status of the patient, will use normal saline to increase the blood pressure, because it's going to lower the blood pressure, and you don't want a problem. Just refer to the chapter related to that. And if you have any questions about any of this, you want to email me. Just remember how it suppresses the nervous system and the side effects that it can happen. And that is the conclusion of chapter 18, Depressants.